Hello, good afternoon, everybody. My name is David Butler, and I'm here to talk to you about some real-world deployments of telemedicine that have been taking place with acute trusts and CCGs around the country over the last 2 or 3 years. I want to talk to you about 3 companies, if I can just create a little bit of confusion to begin with. A company called Involve, an organisation called Airedale NHS Foundation Trust, and a company called Cisco. Let me first of all start off by giving you a little bit of information about Involve. We're a technology company who've worked in high trust service critical environments for about 20 years. And we have a rich history of providing secure video services into places like the Prisons and Courts Service, where we provide the vital links from the prisons into the courtrooms, which is increasing efficiency and saving great amounts of money. We're also very proud to be the video technology provider to the Welsh Government, and that ranges from business efficiency tools right through to control and command rooms. And we're also very proud to have been a partner of Cisco for the last 10 years, who've invited us here today to present to you. So, Involve, about 7 years ago, were contacted by Airedale Foundation Trust. Airedale were looking to remap their business model and to start to generate some revenues by providing their clinical services to other trusts around the UK. Their first target was to look at an opportunity that they'd seen within the UK Prison Service. And so the link was made to us through the work that we do with the Ministry of Justice and the Prisons and Courts Service. Airedale wanted us to provide secure video links into UK prisons through which they could provide telemedicine services. We'll talk more about that a little bit later on, but we did that quite successfully. And over the following years, the relationship between us got closer. We worked on an increasing number of initiatives. A large number of CCGs and acute trusts were knocking on our door, very interested in what we were doing and interested in procuring some of these remote clinical services and technology solutions from us. By 2011, the number of these inquiries was increasing quite significantly. And our 2 organisations were almost totally interwoven in the telemedicine arena. We decided that if we were going to scale this, the appropriate vehicle to do that through would be a joint venture. So we formed an organisation called Medicare, which is a 50-50 joint venture between Airedale Foundation Trust and Involve. Medicare is a unique vehicle that allows us to go out to UK CCGs and acute trusts and provide clinical services and technology directly to them. So, just for the avoidance of doubt, everything that I want to talk to you about over the next 20-30 minutes is based around video. And this is a very simple recipe, really. When we first set out there were 2 key things that we wanted to achieve. First of all, we wanted to reduce avoidable attendances and admissions by using this technology to allow clinicians to make a visual assessment of a patient before they presented in a traditional healthcare delivery environment and setting. The second key objective was to reduce length of stay by using the technology to give confidence to carers, patients, and their relatives, to support early supported discharge. Thereby, imagine an elderly resident going back to a nursing home or a care home environment, giving the staff there the confidence that they have a video link directly back into an acute environment, means that they're willing to take those residents back much earlier. So let me just talk you through some of the real-world things that we've been doing and share some data with you in terms of our outcomes and things that we've observed. So our first venture into telemedicine, as I said, was within the UK prisons. So we deployed across 22 UK prison sites with a mix of category A, B and C prisoners. The business model for the prison service was absolutely crystal clear. The cost of transporting prisoners to and from prisons into healthcare environments is extremely high, it's disruptive, and any number of other issues associated with it. So we installed the telecards across the 22 sites, and over a 12-month period, the patient flow from those prisons into traditional healthcare settings reduced by 50%. Now that's a significant number. More importantly to me, that validated the technology as a clinical assessment tool for assessing and trauma and triage and all the other good stuff going on. It really said this video stuff works in this environment. That service has gone on to grow, and it now provides scheduled and unscheduled care. And some of the scheduled appointments from consultants based up at Airedale Hospital, looking after patients in prisons right across the UK. Another application that deployment that we have out there, which we're very proud of, is our stroke network. We currently have the UK's largest stroke network, which is based up in Yorkshire and Humber. Working with the NHS England Northern Senate, we identified a number of local hospitals who wanted to provide the local population with a 24-hour stroke service, but just didn't have the resources to do that from a staffing perspective. So we put similar technology that we use in the prisons into these local EDs, and there were 18 in total, and we built a network of 70 consultants who use laptops and video technology to communicate with those EDs from wherever they are. And they can make an assessment, diagnosis to thrombolyse the patient from their offices, from their homes, and from wherever. So we've now got an environment where several hundred patients have gone through this, and they've received thrombolysis treatment within the 4.5-hour window, which they otherwise wouldn't have been able to do. I can waffle on about this for hours, but much better if I hand over to Leeds A&E, and I'll let them show you how they've been putting this technology to use.
If you're suspected of having a stroke, there's a saying among medics, time is brain. There's a short 4.5-hour window for assessment and treatment to ensure your brain cells don't die. That can make the vital difference to your outcome.
Julie, I'm just going to phone Dr. Bamford now.
Julie, our volunteer, is suspected of having a stroke. She's had a brain scan, but the consultant who can analyse it is not in Leeds A&E.
We have a lady here, Julie. We've done a head CT scan, and I think she's having a stroke. And I think we need an expert opinion on whether or not we can thrombolyse her.
Hello, Mrs. Hemingway. And what were you doing when the weakness of the right arm and leg came on?
I was hoovering in the living room.
With the assistance of technology and brain attack nurse specialist Alistair, Dr. Bamford can see the scans.
We can see where the problem is. There's a clot in the left middle cerebral artery.
Diagnosis stroke. Julie does need to have a clot-busting drug fast. As long as the consultant has access to a laptop and broadband, diagnosis can happen anywhere, from his office, home, or another clinic.
The Strategic Health Authority has funded the same equipment in all the hospitals in the region. In theory, I could do the same interview with a patient, say in Wakefield or Sheffield or Hull.
We're looking at a 24-hour service. Currently, we don't have that, so we can offer thrombolysis 24 hours a day, 7 days a week.
It will hopefully allow the availability of this treatment to increase over the next 6 to 12 months. We know that thrombolysis increases your chance of walking out of hospital free of disability. It's not a guarantee, but it increases your chance of that.
So don't be too surprised if a camera and a monitor greet you in your local hospital. After stroke care, this system could be used for many other acute specialisms. Penny Bustin, BBC Look North, Leeds.
Okay, so we've now got that technology well embedded in those hospitals across Yorkshire. We've recently just deployed a pilot solution with the Heart of England Foundation Trust, and we're continuing to see increasing interest in the development of these stroke networks, which have typically been operated over telephones in the past. One of the most interesting areas that we've worked in, and I think one of the areas that we're best known for so far, is our work within residential care and nursing homes. It became clear once we set out on this telemedicine journey that actually collective cohort of patient was quite attractive. It meant that you could have a relatively low investment piece of equipment deployed into a group of patients who could then be supported remotely by our clinical team. And one of the cornerstones of our current offering through Medicare is what we call our telehealth hub. And it's at Airedale Hospital in Yorkshire. And it's fully staffed by Band 6 and 7 acute care nurses, 24/7, 365. They are supported, and clinical responsibility for the hub sits with a consultant physician. We've now started to develop that team into a small MDT. We've got full specialists, geriatricians, and specialist cancer nurses, and a bunch of other specially trained people who can help the residents out in those environments with whatever particular conditions that they're dealing with. We're currently deployed in just over 200 homes across the UK, and we have a further 200 ready to be deployed. We currently run at Airedale, everything runs on System 1. We've been successful in deploying some interface with EMIS through the MIG, where we're able to deliver information that's created in System 1 during a consultation into the local patient record, wherever their GP happens to be, and given a notification that record's been updated. So we're able to create a complete loop. At the care home end, we didn't want to price this beyond the budgets and desires of the CCGs. So we're deploying simply a laptop with a high definition camera on a clinical trolley that can be moved around from resident's room to room. Also importantly, and I think this is something that we provide outside of the NHS operations, we've got a team of engineers who are able to go out to these care homes and provide all the support and engineering and things that they need. Again, I'm not going to waffle on about this. What I want to do is hand you over to Dorothy and Nurse Lynn, who are going to show you just how this works in the real world.
Has it healed your finger?
Are you able to hold it up? Oh, that's fabulous.
At the age of 93, Dorothy Casford is using 21st century technology to receive NHS treatment in the comfort of her own home. Dorothy needed medical advice, but rather than face an arduous ambulance journey and a long wait at A&E, she called up a local hospital's 24-hour-a-day urgent care centre.
It saved a long wait at hospital, and I got attention through, first of all, they asked to look at it on the television, and then they told me what to do.
We've kept Dorothy out of hospital.
Schemes like this one at Airedale Hospital, treating patients closer to home and reducing hospital admissions, are seen as key to the future of the NHS in England. With an ageing population, expensive new treatments and limited resources, health service leaders have come up with what they say are radical proposals for the next 5 years.
We're saying that into the future, if we do everything we can to make the NHS as productive as possible, to accommodate the fact that the population's getting larger and getting older, we do need a bit more than inflation, maybe about 1.5% more than inflation each year.
The predicted funding gap for the NHS in England is driving big changes. The health services in Scotland, Wales and Northern Ireland face similar pressures. This is an ambitious plan. Keeping more of us out of hospital and reducing the burden on the NHS will need not just money, but a big cultural change as well.
Okay, so we've been running this service now for a few years, and we've got some data which we can share with you, which gives an indication of how effective this can be. So on the right-hand side, there are some figures based around acute admissions and attendances and length of stay. So we're fairly new. We don't have a massive database of stats to share with you, but we've got some indicative information that's really pricking the ears up of commissioners around the country. So this data was gathered from a group of 35 homes, and it looked at hospital episode stats 12 months pre and 12 months post the implementation of telemed. The homes remained constant throughout the pilot, and the patients varied between 1,700 and 2,250. And what we saw was that the acute admissions rate reduced from those homes by 35% over the period of time that the service was in there. The attendance is reduced by 53%, and given some of the winter pressures we've just seen, that would be a welcome figure at most A&Es. And interestingly, the length of stay reduced by 59%. Now, as I said, the care homes have now got this vital video link into an acute trust. Their willingness to take residents back early, their confidence has increased, and so they take them. Hence, it helps with the bed blocking issues as well. It's begun to morph. We've now been delivering it for CCG and acute trusts and hospital trusts throughout the country. What we've seen is that actually they're trying to create more cross-service working now. So we're starting to see deployments which incorporate the care homes, which can be supported by our nursing hub during the out-of-hours period, 2100 till 0900. During the day, they're trying to create local GP-neutral solutions where they have community matrons, geriatricians, urgent care teams, their local ambulance service, all equipped with this technology. So they can provide all of this service wrap to this resident without moving them out of that home environment. How do we do this? Well, we currently have a network infrastructure platform that sits in the Airedale data centres. It's been put together in a fully redundant array. It's all standards-based Cisco infrastructure. And it's allowing us to stream absolutely secure video calls between the internet, which is where a lot of these care homes and a lot of the patients are, back into the clinicians who are inside the N3. All of the activities that are taking place at Airedale have gone through the IG toolkit. They meet all of the current security guidelines, and everything that we're doing is compliant. Interestingly enough, we've also been sharing this network with a few people. Some of our customers, particularly the acute trusts, have got their own ideas for telemedicine pilots, with video at the center of it. Investing in that infrastructure really can't be justified until they've got some data and the outcomes from their pilots are known. So in addition to the other things that we're doing, we're saying to people, look, we'll provide you with access to this network to run your pilot on for 12 months. At the end of the pilot, you'll have some data. If it's proved successful, create a business case, get the funding and the executive support, and then build a local infrastructure. It's all open standards, and then we can migrate the managed service connections over to your local infrastructure platform. So it's a very low-cost, progressive way to deploy telemedicine locally. So what of the future? If only we all had a crystal ball. For me, the future with video is fairly clear. And I think on the next slide, you'll see some of the commentary that supports that. And the future for me looks like people with devices. There are more SIM cards out there now than there are people. Broadband is proliferating across the country. And actually, I see people with any number of video interfaces, be it a client-based Cisco application, be it a Skype interface, whatever. Being able to reach into contact centers, which could be 111, they could be local hospitals, they could be a GP-led service, or it could be a dedicated nurse-led service like we're running at Airedale. That contact center brings all those people into what we call a professional video environment, where we've got call management and transfer and all that good stuff. And then those contact centers can share that load with clinical resources, which could be distributed locally, nationally. It's all about collaboration as we go forward. A few things, just general learnings from me. I mean, I've worked with trusts across the country and CCGs. Just some of the things I've learned as I've gone along. The first one is that you're going to need executive support if you really want to do this. And you need some leads who are going to say, do you know what? We're going to put all that stuff that's going to stop this over here, and we're going to drag the enthusiasm and appetite over this side. My advice is to make sure that when you look at telemedicine, don't throw the technology out there hoping that people will find an application for it. Get a very clearly defined process, then give them the technology as the enabler to deliver that. As you go through that process, the type of service that you're going to run will become clear. If you've got long-term patients with complex conditions who you're going to be supporting on a regular basis, it may justify providing them with a shiny device, and you may have a client-based solution where they can hit a green button and call the clinical team at any time. If it's for less frequent contact, wider population, it could be a clientless-based solution. We're working on a few at the moment. One of them is within renal, where we're creating an online portal. Patients are entering some details, then they're hitting an escalate to video button, and then they're being brought into a video environment, which is sitting with inside an acute trust. Some other advice here, I would say take a very holistic approach to technology. I was talking to Joan from Cisco earlier this morning. If you set off on lots of different pilots with lots of different technology, what you'll get to is a mid-stage where actually you can't connect all of those together. So therefore, you can't leverage true value from your investment. So look at the overall organization in terms of technology. And as a final point to this, the word telemedicine I find quite confusing sometimes. I mean, for me, this is really just about a huge communication system with pictures. So while you're looking at telemedicine, remember that this also becomes a business efficiency tool within trusts. We recently deployed a solution within a large CCG and a CSU, and they've put 300 people onto a video-based system to do partly telemedicine, but to save £1 million a year traveling to meetings and things. So it becomes a whole solution. We're well documented. We've got lots of people who turn up at the Airedale Hub with cameras and movie teams and all sorts of stuff going on. We're also mentioned in the 5-year forward view And there's a nice comment at the bottom there which says that, in some places the future's already emerging. For example, in places like Airedale. So this really isn't big blue sky thinking, it's happening today. And we'd love to talk to you about it if there's interest. So that's me done talking. I'd like to throw it open now to the floor and just see if there's any questions that we can answer for you while we're here. Is there a microphone?
Yeah, I was just, how does the consultation, the event, actually get recorded as part of that patient's record then?
Okay, so let's imagine for a moment that I'm a nurse in Airedale and you're a resident in Kent. So you've come through to the hub with your carer potentially, and I am using my nursing skills to make an assessment. While all of that goes on, I'll be entering the consultation record via System 1 locally within the Airedale hub. So a physical record is created. If I then have a MIG interface with your local practice, that will naturally get populated into your local patient record. Alternatively, we'll make a hard copy and then forward that through a secure mail service to your GP. So that loop is completely closed.
Thank you.
I'm John Brenton from Cisco. Just want to ask you, David, we were listening in the last speakers talking about partnerships and moving forward. And I've worked for, as you know, many years in telemedicine. And have you found working in a partnership with an NHS trust has made adoption easier? Because adoption and implementation is the hardest thing to move telemedicine forward.
Yeah, it's been a fascinating journey, Jonah. Thanks for asking the question. It's much appreciated. Clearly, within the private sector and the NHS environment, these are two totally different groups of people with slightly different objectives. On this side, developing products, hitting sales targets, and on this side, providing care. So initially, yeah, there was some buffeting as we started to work with the trust. However, I think we've both learned to understand and, more importantly, benefit from each other's capabilities. So when I go out and talk about technology with people, bringing the Airedale story and the clinicians from Airedale to share their experience and to give advice on how to implement this clinically, it has a much greater impact than if I just sat there talking about video technology and infrastructure. And I find that's true with all of the trusts that I go to now. I actually don't talk very much to IT directors. Cisco are very good at doing that on the infrastructure side. I find myself really presenting within the hospital trust, so the clinical directors forums and people like that. Within the CCGs, it's the clinical leads, transformation managers, and it's very much about hitting all the objectives. So improve care, and reducing the pinch points within the system, and of course saving money as we go along the road.
Thanks very much. I'm Julian Halcox. I'm a cardiologist. Hi. Could you talk a little bit about your business model? Because obviously there's the challenge firstly of adopting and obviously then monetizing and growing the business. Is it done through license fees, through paid for service, for individual patients or individual practices, commissioning groups? How does it work? Okay, so it's interesting you asked that question. Thank you for that. We have a number of models driven really by the requirements of the people that we're providing the service to. So we've put care home deployments out in a number of areas where it's been funded directly by their local hospital or acute trust because they're under acute pressure at their ED door and they've got bed blocking issues and they really just want to try and take some of that pressure away. We've other deployments where it's been funded by the CCG, whose requirement is to reduce their expenditure and to get all these events under control. The business model's actually incredibly, we think, probably too cheap at the moment. We can provide a year's service of this into a care home at a lower cost than one admission. Okay, are we done? Listen, it's been an absolute privilege to come here. Thanks very much indeed for listening to me. And I think it's lunchtime.